This is the second in a 3-series video on analgesics and antipyretics for the Self-Care and Complementary Medicines course. As discussed in the last video, this is the cyclooxygenase cascade, and here you can see NSAIDs, which we're going to talk about this time, have activity on both COX-1 and COX-2. So due to both central and peripheral inhibition of the COX enzymes, both 1 and 2, this leads to the inhibition of prostaglandin synthesis. One thing that's important to keep in mind is that the NSAIDs, or nonsteroidal anti-inflammatory drugs, do have anti-inflammatory activity. Their onset of activity is 30 minutes, again, very similar to the other products that we're talking about. And their duration varies just slightly. Ibuprofen products tend to last about 6 to 8 hours, and naproxen lasts anywhere from 8 to 12 hours. Both are absorbed rapidly by the GI tract, and they're metabolized by the liver and eliminated by the kidneys. Our first product, ibuprofen, under the brand names Motrin and Advil. Normal adult dosing for over-the-counter is between 2 and 400 milligrams given every 4 to 6 hours. Pediatric dosing is 5 to 10 milligrams per kilogram per dose every 6 to 8 hours. One thing you'll notice here is that this is slightly different than the dosing for acetaminophen as discussed in video 1. A good way to remember is that ibuprofen is always going to be on the lower end, 5 to 10 milligrams per kilogram. Acetaminophen is on the higher end, 10 to 15 milligrams per kilogram per dose. But in all actuality, if you can remember that 10 milligrams per kilogram is a regular or a normal dose for both NSAIDs like ibuprofen and acetaminophen, you should be able to easily remember that. The maximum dose for over-the-counter use is 1,200 milligrams per day. And please keep in mind that ibuprofen should not be used in children under the age of 6 months. Naproxen, under the brand name Aleve, comes in for adult dosing is 220 milligrams given again every 8 to 12 hours. One thing to differentiate is that naproxen is only indicated for patients 12 years and older. And the maximum daily dose is 660 milligrams per day. Easy to figure out, you just take 220 milligrams if given every 8 hours, that gives you 3 doses per day, or 660 milligrams per day. Caution should be used in using these products in pregnancy, particularly in the 3rd trimester. Common adverse effects typically are GI related with dyspepsia, nausea, vomiting, heartburn, and abdominal pain. So it is recommended that all patients take these products with food. Products that have enteric coating may help reduce the risk, but not necessarily. And there is a cross-sensitivity with aspirin allergy of about 95%. So that means that if a patient has an aspirin allergy, they have about a 95% chance that they also have an NSAID allergy. So keep this in mind when recommending to a patient. It's important to mention that the NSAIDs do have a black box warning for 2 things. First, for cardiovascular risk. NSAIDs may cause an increased risk of serious cardiovascular events like heart attack and stroke. And the risk may increase with the duration of use and in patients with risk factors for cardiovascular disease. And they're actually contraindicated in the treatment of pain following a CABG. GI risk is also a concern. NSAIDs may cause an increased risk of serious GI reactions, including bleeding, ulceration, and perforation. Both cardiovascular and GI events can be fatal and may occur at any time during therapy and without warning. Therefore, we always want to recommend the lowest dose for the shortest period of time. So if we're looking at a patient, some risk factors to consider for cardiovascular disease would be a history of congestive heart failure, renal deficiency, or hypertension. These products should not be used in patients who have had a prior myocardial infarction, or also known as a heart attack, because it increases their risk of death. And there also is a concern for acute renal failure risk. Inhibition of prostaglandin synthesis with an NSAID leads to reversible renal ischemia, thereby causing a decline in glomerular hydraulic pressure and ARI. The efferent arteriole controlled by angiotensin II leads to the ACE and ARBs actually can inhibit the vasoconstriction, causing vasodilation, and this results in a significant decrease in renal function, thereby causing an acute renal injury. Risk factors for a GI bleed include a patient having a history of peptic ulcer or GI bleed, other medications that may increase their GI bleed risk like aspirin, warfarin, or on steroids, if they're over the age of 60, if they have an H. pylori infection, or if they have NSAID-related dyspepsia, or they use alcohol regularly, and that's consuming more than 3 drinks per day. All of these can increase the risk of GI bleeds. Other medications to keep in mind could be NSAIDs, other anticoagulation, antiplatelets, bisphosphonates, SSRIs, and high-dose aspirin. If a patient has a history of a GI bleed or peptic ulcer, we should avoid NSAIDs when possible. And if a medical conditions require the use of an NSAID, we need to use a proton pump inhibitor like omeprazole for gastric protection. This chart discusses some of the common drug interactions that are consistent with the use of NSAIDs. While it's not required for you to remember, I wanted to highlight on this chart so that you could remember for the future what some of the common drug interactions are. With aspirin, anticoagulants, digoxin, antihypertensives, methotrexate, and bisphosphonates. All of this information comes from Table 5.5 in your chapter.